opportunity yesterday. It was really a special day in honor of Professor Frank Shan. It was something really, really outstanding. I wanted to tell you a little bit, here are my disclosures, tell you a little bit about what we're up to at the University of Pittsburgh, trying to come up with some new strategies for brain injury in children and adults. I have a center that has as many adult investigators as pediatric investigators. We're all motivated. It's the Saffer Center by the great Peter Saffer, who of course developed CPR in 1956, and it's been my 20th year, actually, as the director of the Saffer Center, so it's pretty crazy that I've been the director of the Saffer Center longer than Peter Saffer was the director. But Peter Saffer was such a special guy that I thought what I'd do is sprinkle some Peter Saffer thoughts in through this talk. We all, I think, in the ICU feel that the brain is the final frontier. It's becoming pretty clear that long-term outcomes are what are important now, and not mortality so much. We've done a pretty good job with that, but morbidity. And we're really interested in resuscitating and treating the injured brain, but also in care of the uninjured brain during a critical illness. Our center's interested in the ICU, we're interested in the field, and we have a great advantage of having a beautiful group of both basic scientists and clinician scientists working together. And so we really do go from the cell to complex animal models to the patient. And I'd like to show you that in my talk today. I think you'll see that we really have people working on the whole thing. We study two diseases, traumatic brain injury and cardiac arrest, but today we're just going to focus on traumatic brain injury. And why traumatic brain injury? Well, I think right now we finally have realized there is a traumatic brain injury epidemic that we just haven't been paying attention to. In the U.S., according to the CDC, you see 1.7 million people suffer traumatic brain injury, and actually the prevalence is very similar in Australia, 176,000 cases annually. According to the Department of Defense in the United States, 74% of U.S. military casualties during the Iraq and Afghan conflicts were associated with blast. And now what's happening, there are 202,000 patients coming into veterans' hospitals with long-term symptoms and sequelae of multiple blasts. Some of these guys exposed to 20, 30, 50, 70 blast exposures. And according to the CDC in the United States, over 37,000 children suffered traumatic brain injury per year, and over 7,000 die. And now, if you've been paying attention to CNN, you see that traumatic brain injury is being linked to every chronic neurodegenerative disease under the sun. And so we're learning that sports concussion now is progressing to chronic neurodegeneration. And this has had quite an impact, and I think it's really going to be important to us in the ICU. And because it's become the golden age of traumatic brain injury research. 10 years ago, we put a grant in, if we put a grant into the National Institute of Health and tried to put both a laboratory and a clinical aim, they'd say, traumatic brain injury is too messy. You can't study it. Now, you must study this. And so it really is a fantastic thing in complementing our traditional NIH funding. There are over 600 grants funded by the United States Army now, also in traumatic brain injury. So we're very unusual. Here we're pediatric people doing actually research funded in many cases by the United States Army. So it's really a special time, and we better get some answers now if we're ever going to have a chance at getting some answers. And we have a number of really interesting programs going on. The ADAPT trial, which is a comparative effectiveness trial, the pediatric brain injury, inflicted brain injury trial, Dave Okonkwo on the adult side with Team TBI, and I'll tell you a little bit about Operation Brain Trauma Therapy. These are the investigators I have working on traumatic brain injury, and a few of these also on cardiac arrest. We have a special emphasis on studies in children. I've been very fortunate now for 14 years to have a T32 grant from the National Institute of Child Health. It funds 4 fellows. We have 14 fellows in our pediatric critical care program. And we also have a pediatric critical care or pediatric neurointensive care service, specific with 5 NIH-funded faculty that take care of all of the patients. It is a virtual service. It doesn't have its own unit, but it consults on every patient with a neurologic problem in our unit. One of the things you'd say, though, and that is that, and we talked about it yesterday, is that all the traumatic brain injury RCTs have failed except one, and I'll tell you about that a little bit later. And so if you've had a system failure, you need to look carefully at why, and we'll talk a little bit about maybe what I think as to why the causes are and what we're trying to do about it. One is people have said traumatic brain injury is not a single disease. You need to phenotype it. Another is care is too heterogeneous. Another is, what about personalized medicine? And what about brain edema? We've been using the same stuff for 50 years. Come on, don't we have anything new? And what about targets beyond ICP and other secondary injury targets? I'll take a look a little bit about maybe the trials have failed because the laboratory studies are wrong. We'll talk a little bit about the blood-brain barrier, a little bit about mitochondria, and then close on 2 things: the role of rehab and to block neurodegeneration, and then a little bit about our international project of prevalence of neurocritical care in children worldwide. So how do we turn failure to success? Well, here are some of the strategies. What about traumatic brain injury as a single disease? You've all seen this cover in the Journal of Neurotrauma showing, as I call it, 6 ways to get to a Glasgow coma scale of 4. You'd argue all of these CTs look like a different disease. Are we trying to treat traumatic brain injury as if we were treating cancer as a single disease? That may be a big problem. What about phenotyping? Well, to some extent, the place to look for this is in the mild traumatic brain injury literature, because this is the rage now in the mild traumatic brain injury literature. Because the patient's symptoms in mild traumatic brain injury may be a sleep disorder, for instance, or cognitive dysfunction, or hearing difficulties, or the spectrum of symptoms are so diverse, headache, etc. And we haven't focused that way in severe TBI. And there are several programs. One, Jeff Manley's looking at this, and if you're interested, that's called Track TBI. But let me tell you a little bit about the Pittsburgh program, and this is Dave Okonkwo's program. This is funded by the United States Army. It's called Team TBI. It brings together small groups of mild and moderate TBI patients, clusters them into specific phenotypes, follows them with various treatment regimens over 6 months. And here's an example. You can see here's a baseline mild TBI patient. This patient's biggest problem is a sleep disorder and with some vestibular problems, etc., etc. And then 1 month later looks at, well, what's happening? And you see the sleep disorders improved, but the cognitive problem is still there, etc. And so this is a really interesting strategy, and I think it's really overdue. And I think we will start to see this kind of approach in severe TBI as we are moving forward. We really need this approach in severe TBI. But you could argue that, well, even if we phenotype, the background care is too heterogeneous, and this was brought to light so clearly in the hypothermia trials that have been done in adults where patients received between a negative 10 liters and 20 liter fluid balance on the same protocol, all targeting CPP, but everyone doing it a different way. And so how do you test a therapy in the face of this? And Peter Safra used to say, boy, the noise is so great in acute clinical trials. We're trying to do something about this, and one of my former trainees, Mike Bell, is leading the ADAPT trial right now. It's a comparative effectiveness trial in pediatric traumatic brain injury, 32-center, 1,000-patient trial, probably the largest trial in the history of pediatric traumatic brain injury, looking at what are we currently doing. Let's take advantages of differences in the various centers, even though everyone's following the guidelines. The guidelines are so weak, I mean, you can do almost whatever you want and still follow the guidelines. What is it that seems to come booming through? And this might help us not only change the guidelines, but come up with what the best strategies for future RCTs are, and maybe provide some clues as to what to test. Here are the centers involved in this, and I know that some centers in Australia and New Zealand are also being recruited into this by Mike. What are the questions? They're the key central questions in management. ICP management, brain tissue O2 nutrition, hyperventilation, CSF diversion, osmolar therapy, and glucose management. These are the key things that we're looking at. 146 patients have already been entered. And this is a really great thing because there's no therapy. So everyone basically gets entered. We've had only a few patients turn this down because all you're doing is following normal care. This is an exciting study, and we're really looking forward to this. But we're in the era of personalized medicine. Can we do something even more? And what about kind of a personalized medicine approach and or precision medicine, as it's being called? Well, we're doing some studies in this, our Rehab group, looking at post-traumatic seizures. And so I'll give you one example of how we're trying to think about traumatic brain injury from a personalized medicine standpoint. 5% of all seizures are post-traumatic seizures, and 20% of all symptomatic seizures. And post-traumatic seizures in a severe TBI, Paul Vespa's classic paper, they're common and they're associated with badness, if you're interested. Chronic post-traumatic seizures are also a big problem in rehab. Anticonvulsants have side effects, the unknown effects on plasticity. Dilantin is a classic culprit in that regard with chronic use. Normally, we have two anticonvulsant systems operating in our brain. We have the GABA system, and you're all familiar with GABA. I mean, we use barbiturates, for instance. But we have the adenosine system, and the adenosine system is as powerful as the GABA system, but we don't know very much about it. It's operated through the adenosine A1 receptor. There are many adenosine receptors, but the anticonvulsant effects are at the A1 receptor. And I published a study several years ago that's getting a lot of attention now. We took adenosine A1 receptor knockout mice, gave them a head injury. And you see a normal mouse at the top after a head injury, and it just walks around in its cage. And you look at the bottom at the adenosine A1 receptor knockout mouse. So it doesn't have adenosine, which is a good guy. It's like GABA. And you see the mouse comes out of anesthesia after a head injury and immediately goes into intermittent status epilepticus. So this is a really, really powerful endogenous anticonvulsant system that you have. And we published this, and as I said, it's getting a lot of attention. And so you'd say, people have said, well, mice, they don't tell you anything. I don't know if you saw the septic shock studies. Well, what about humans? There are a number of genetic polymorphisms of adenosine A1 receptors. And it turns out that we have probably the world's largest DNA bank of head-injured adults. And so we said, let's look and see if there's an association between genetic polymorphisms of A1 receptor and post-traumatic seizures in adults. So we looked at two tagging SNPs, and damn, if you had these both risk genotypes, you had an almost 50% chance of having a post-traumatic seizure. In contrast, on average, about 12% of the population has post-traumatic seizures. So this quadruples your chance of having a post-traumatic seizure. And so this, I think, is just an example showing that genetic phenotyping could be really important when we come in and say, hey, this is a patient that is going to probably need long-term anticonvulsants. So it's just one example. I think personalized medicine, we're really at the tip of the iceberg on it. It also shows that mice aren't so bad for predicting what a human is going to do. Well, what about new therapies? I mentioned brain edema. And, you can say Alfred E. Newman saying, come on, pitiful, mannitol, hypertonic saline, decompressive craniectomy, CSF drainage. That's all we have. We have all these drugs and different diseases. We have nothing new. Well, this is an area that I think is really exciting right now. It's one of the hottest areas in drug development in brain injury, and that is targeting astrocyte swelling. There are a lot of ways the brain swells after injury, but astrocyte swelling is where most of the action is. Are there any new magic bullets? If you're interested, take a look at this paper by Laird in the journal Glia, and it's really interesting. Astrocytes do a lot of good things. They swell to defend neurons, but there's a price to pay for it. And it's really interesting, if you follow the sepsis literature, you see that the danger signals, things like HMGB1, etc., endotoxin, are playing an important role, and they're playing an important role in brain injury. If you injure neurons and some of them die, they release HMGB1, which bind to toll receptors. You've seen this in the sepsis literature. And interestingly, the IL-6 produced by toll receptors upregulates aquaporin-4 in your astrocytes. And so this molecular cascade is driving astrocyte swelling and at water accumulation. So, well, does this happen in people? Here's HMGB1 levels that we just published last year in CSF from head-injured kids. And you can see a marked and sustained increase. And then, of course, IL-1 levels dramatically go up in CSF. So this molecular cascade is present. We now have drugs that are being tested, aquaporin antagonists, toll receptor antagonists, HMGB1 antagonists, and so there are a lot of really cool new targets. There's also SIR1 antagonist, the drug glyburide, which I think could be very important, and there have been a number of studies on that drug in stroke from the University of Maryland. So I say keep your eye out. That we really have some new drugs that are being tested right now, and we may actually have something, you want to call it the new mannitol, that will work on a specific mechanism. You could argue we'll just do a decompressive craniectomy, and you guys here in Australia and New Zealand did a very important study and published in the New England Journal showing great ICP control from a decompressive craniectomy, but the patients actually had worse long-term outcome. And my take on this study is interesting that some have argued, well, there was a flawed surgical approach, but maybe all the therapies we use in neurocritical care, sedatives, analgesics, hyperosmolar agents, barbiturates, have beneficial effects other than those just on ICP. In our patient population in kids, the kids we have the most difficulty are the infants. If you have a severe head injury under 2, you have the poorest outcome. Not everyone monitors ICP in these infants. They say, well, they have an open fontanelle. We monitor ICP on all of them. And when we looked at our data, and this is published a couple of years ago now, it's really interesting that overall in our unit we had excellent outcome, an 8.6% mortality rate, which is way better than the national average. But when we looked at the infants, 11 out of 22 had an unfavorable outcome, but only 2 of them had refractory intracranial hypertension. In 9 of the 11 infants, 900 hourly readings of ICP, there were only 8 readings greater than 20. So this would argue that, maybe we shouldn't forget about ICP, but hey, maybe we need some additional targets. And what are those targets? There are a lot in traumatic brain injury, and you could argue, well, there's a lot of mechanisms, how are you ever going to figure that out? But you could say the cup's half full. And one mechanism that I think we've not paid enough attention to is axonal injury. And in traumatic brain injury, there's dramatic axonal injury. If you look at myelin basic protein levels, people follow that in multiple sclerosis. Take a look at traumatic brain injury. Here's CSF myelin basic proteins. The dotted line is the normal control level. These aren't twofold or threefold increases. They're thousandfold increases in myelin basic protein in CSF. So your axons are melting after severe traumatic brain injury, and boy, they're melting for a long time. Look at the sustained increase in this. John Pavlischak, the world's expert on axonal injury at the Medical College of Virginia, and also the editor-in-chief of the Journal of Neurotrauma, says this is the tip of the iceberg because you have as many unmyelinated axons as you have myelinated. And presumably all of them are being sheared and injured. No current therapy we use targets axonal injury. And so this could be a very friendly target. One of the beautiful things now is that we have much more advanced imaging to look at this. And you guys are, I'm sure, all familiar and use diffusion tensor imaging. What we have been developing at the University of Pittsburgh is something I think even more special called high-definition fiber tract imaging. If you're interested, Sam Shin up there in the corner, a MD, PhD student, neurosurgeon, was the top trainee in our center, published a beautiful paper on this, a technique pioneered by Walter Schneider in the Journal of Neurosurgery. And this patient here is shown with both standard DTI and high-definition fiber tracking. And I think you can see the high-definition fiber tracking is amazing in how it can potentially outline the loss of white matter tracks, which are pretty dramatic in this patient. So now we have biochemical ways and imaging ways to monitor. Well, what about future therapies? I mentioned the Army is funding a lot of studies, and unlike an NIH grant, which is interested in the mechanism, the Army wants answers. They want therapies, and so I'm very fortunate to be leading something very different than the NIH molecular mechanism strategy. As Peter Safar would say, we need a National Institute of Health, not mechanisms. And that is something to try to target this. You'd say, okay, one strategy is this personalized medicine strategy. What about a drug that would work on everything? Well, if you get something to work on everything, maybe you might need to test it in essentially all of these at the same time. And how might you do that to get a robust therapy? And develop a drug that would work on everything? Well, let's put together a consortium of preclinical traumatic brain injury modeling centers and test the drug rigorously, or test a series of drugs across multiple centers. And we are doing this. I'm very fortunate to be leading this in the United States, called Operation Brain Trauma Therapy, the Miami Project to Cure Paralysis, Virginia Commonwealth University, Walter Reed Army Institute of Research, and our center are all testing drugs in totally different animal models. And we want to see, is there a big winner, basically. I only have time to just give you a really brief thumbnail, but you can see here are the three animal models that are being used. They're very different. One produces a mild injury, another produces a severe contusion, and another is a penetrating injury. And so there are three very different lesions, and if something hits, then we push it up from the rat to the pig and test it in a large animal model. And this is a very, very cool project. We also test serum biomarkers in every animal, and we've tested probably 5,000 biomarker levels. Well, what about therapies? Here are some of the therapies we've been testing: nicotinamide, erythropoietin, cyclosporin, simvastatin, glyburide, levetiracetam, and then some futuristic therapies: VA64, NIM811, AER, which is an aquaporin receptor blocker, just for your interest. This is a very exciting project. What are we finding? First four therapies, look at that. 24 preclinical studies in animal models on EPO that said it was beneficial. We saw almost no benefit. And all of these first four therapies did not look very promising. And in general, it suggested to us that the literature is overly optimistic. And this is very similar to cancer research. I don't know if you've paid attention, but Amgen tried to reproduce 53 landmark preclinical studies in cancer. and they were able to reproduce 6. And so you'd say, well, you know, people look at their data in the most favorable light. They exclude outliers. They do things. Of course, you need to get your grant. But we've had 2 hits in Operation Brain Trauma Therapy, and this is a very rigorous approach. The code is broken at all centers simultaneously on all agents. Everything is randomized, blinded. Both levetiracetam and glyburide are showing some positive results. Not in every model and every outcome, but some real positivity. So I think this is really exciting, and we are, of course, doing much more with these 2 agents. We've just begun using levetiracetam in our pig model at the Virginia Commonwealth University. So stay tuned on this. Another area that I just wanted to briefly mention is the blood-brain barrier. You know, one of the problems with drugs is you've got to get them across the blood-brain barrier. The classic example of this, of course, was in oxidative stress. There's massive oxidative stress in the injured brain after trauma, but the 2 drugs that were tested in big clinical trials over the last decade or so, Terilizad and PEG-SOD, don't even get across the blood-brain barrier very well. So what about a way to target this? And we are in the midst of a clinical trial right now, a small clinical, NIH-funded clinical trial in Pittsburgh, where we're trying to take a drug that we use every day or every week in the ICU that treats oxidative stress, and that's N-acetylcysteine. Of course, you routinely use it to treat Tylenol overdose. Why not use it in TBI? Because it doesn't get into the brain very well. There's a multi-drug resistant transporter that literally pumps it out of your brain. This transporter's in the blood-brain barrier. So why not inhibit it? And it turns out that probenecid, the drug that raises penicillin levels in patients, so it was used in World War II to kind of use penicillin, which was a rare commodity then, also blocks this transporter in the brain. And both probenecid and N-acetylcysteine are FDA approved, so why not combine them? And could you actually get good N-acetylcysteine levels? And here are data from 10 kids, CSF levels of N-acetylcysteine with this strategy showing beautiful increases in N-acetylcysteine in the brain. So this is a 20-patient study, and we're halfway through it, but it looks pretty promising, and it might be a way to take very simple, low-hanging fruit drugs and test them in a trial. Julio Bayer in our group is working on something way more futuristic to try to target this, though, and that is to get the drugs where the free radicals are made. Free radicals, most of them are made in the mitochondria. And they have these hemigrammacidin targeting drugs that have a primordial sequence that makes them kind of like bacteria and home in on your mitochondrial membrane. This mitochondrial targeting sequence then delivers an antioxidant right to the mitochondria. And if you're interested in this, she just published a beautiful paper in Nature Neuroscience. I mean, how many intensivists are publishing in Nature Neuroscience? And it shows that this drug almost completely goes in the mitochondria. You can't find it anywhere else in the cytosol. It gets into the brain beautifully. And when you give an animal traumatic brain injury and you look at oxidative stress in the mitochondria, shown in red, you see there's a massive oxidative stress in the mitochondria, and it's completely eliminated almost by this drug, which is called XJB. And this drug reduces neuronal death, and it improves behavioral outcomes. And these were all done in developing animals, mimicking a pediatric head injury. This drug is also being developed for radiation toxicity and maybe an adjunct in cancer therapy. It has dramatic protection against radiation. And just to close on a couple of points, what about after the ICU? Rehab is extremely hot right now, and I mentioned there was a positive clinical trial in traumatic brain injury. Despite all of our trials in acute medicine failing, the Rehab guys published a beautiful paper using Amantadine showing beneficial effects during rehab on essentially awakening of patients after moderate and severe traumatic brain injury. And this was published in the New England Journal. Amantadine's side effect, if you want to think of it this way, is dopaminergic supplementation. So it's kind of like giving you some neurotransmitter. And if you use it in H1N1, for instance, sometimes patients hallucinate, and it's essentially neurotransmitter release. And so it's an interesting side effect being taken advantage of by Rehab. And this drug was shown to be effective. You may not be aware that the basic science work that was done, that was the basis for this and cited in the paper, was done in our center by Ed Dixon and Amy Wagner and published back in 1999, showing that this drug improved outcome in animals after head injury. Shows you another example how the translation from animal to human can be effective. Rehab is really powerful. If you don't think it's powerful, in our center, if you use what we call a rat rehab cage, and this is enriched environment, and you put the rats in this kind of cage rather than a regular good old-fashioned cage, you know, where you put the two rats in, this approach blows away any drug that you've ever tested for long-term outcome. It has dramatic effects, and actually what is happening, if you measure the cortical thickness of the animals, the cortex thickens, and it's not because they're making a lot of new neurons, they're making a lot of synapses. And so you could argue the real question now is this is such a powerful approach and is also very powerful combined with drugs that maybe the shortest path to success isn't acute therapy, but manipulating the circuitry that we're left with. I think it's an important question, and we're really interested in this. And then finally, I just wanted to mention, we've all seen with all of the sports injuries, the link between neurodegeneration and traumatic brain injury. Most of that work, if you've paid attention to it, is in mild repetitive TBI. And so one of the questions asked is, do you need the repeated injury to trigger the inflammatory response to generate this? Or will we see this, or are we seeing this in the severes? Is this process of neurodegeneration actually getting in the way of recovery a year after a single severe TBI? And it's either amyloid beta accumulation or tau accumulation. But you can see every neurodegenerative disease is linked. Is this happening in the severes? Hilarious that 10 years ago now we published this study where we, in our brain bank, took essentially patients that had decompressive craniectomies and small pieces of the brain that was removed if they had a large contusion, for instance. Rather than just throw them in formalin, we did molecular studies on them, and you can see this is the work of Milos Ekonomik, and what he found is that you see amyloid plaques 2 or 3 days after the injury in these patients. This might be an important target. I talked about this yesterday. I really don't have time to talk about Pangaea, but I just want to mention that Erica Fink in our group is doing a point prevalence study in 107 ICUs in 26 countries and 6 continents, trying to get to the answer of, well, what is the current state of neurocritical care in children right now? And you can see some of her data on the right showing cardiac arrest, status epilepticus, TBI, and Pangaea, I think, could really be important to setting the stage for international trials. So I'd like to close with that. Thank you very much for the invitation to try to give you an idea of what we're working on in Pittsburgh, and I hope that you have a great session here, and once again, thank you very much for the opportunity to speak.
Thank you.